Hello, everyone. I'm really excited to be part of this conference and looking forward to the conversations. I know others will likely be tackling or debating what psychosis is from medical, legal, and lived experience perspectives, or perhaps how we should be approaching psychosis in treatment or in the law. Today, I'll be talking as a sociologist about my observations of how our clinics for the poor versus the rich currently process people, and how this inequality shapes the possibilities and types of recovery people have and can have from mental illness. It's just a little bit of background about me. I came to this work initially wanting to be a clinician, but after working in community mental health care and alongside some service user activists, I became much more interested in these sort of systemic problems, seeing people get stuck in this cycle between streets, jail, shelter, hospital. And this focus on systems eventually led me to training in sociology. And today, I'm an assistant professor of sociology at UC San Diego, where I teach courses on the sociology of mental health and illness, policing, urban policy issues. And now I'm sure some folks have had exposure to sociology, but since others might not, I'll just say a few things about what characterizes the work in this discipline. And so sociologists, we often start trying to gain analytical traction on a given issue or problem by looking at it comparatively. So that might mean looking at the issue cross-culturally, looking at local variation, just even across class in the same area. Helps us see what's unique about the situation at hand, as well as what's general, maybe across cases. And it sometimes helps us see what can sometimes be taken for granted if you just look at things solely in one area. Second, we're quite methodologically pluralistic. So some people use field research, others it's more statistical analysis, others more historical analysis, trying to draw on different social scientific tools to illuminate the issue. And then third, we see our work as focused on understanding social institutions or systems. So we're looking for the kinds of unspoken rules of the game that people have invented for themselves, what gets taken for granted within particular institutions or cultural settings. So this might include policy or legal rules, but also cultural values that might become sacrosanct and then constrain what's possible. So what that means for today's talk is that I'll be juxtaposing treatment in clinics for the rich and the poor. I'll be doing that with comparative ethnography, so long-term immersive fieldwork in different worlds of treatment for the rich and the poor to see how these things operate. And the goal is that by using this comparative lens, things that seem straightforward on their own suddenly become more amenable to critical analysis. And this talk today comes from a section of my new book called Sons, Daughters, and Sidewalk Psychotics, Mental Illness and Homelessness in Los Angeles. And the basic conceit of the book is that after deinstitutionalization, we've had this thing we call community care. We often use that phrase in the singular, but in fact, we have different kinds of community care for people from different communities. And I'm going to argue that we have unequal experiences of illness, of recovery, and even how we think about things like client choice. For people who are deemed beloved kin, on the one hand, the sons and daughters, versus people who are stigmatized and kind of dismissed as social problems, the sidewalk psychotics. And that's where the book's title comes from. And so today, I'm going to be showing how people are processed in different ways that may have less to do with their individual needs or capacities than the systems they are in. And so this takes place not only through differences in the material resources, but also through what I call a social prognosis. And so what do I mean by a social prognosis? So if a psychiatric prognosis describes the predicted duration, course, and function around illness, a social prognosis refers to the types of lives and identities people with the illness can expect to have. And part of what I'm going to argue is that in many cases, it's not actually located in the client, again, and their specificities. It's in the kind of clinical context in which they're receiving treatment. And so here's going to be my argument in a nutshell. My claim is that these social prognoses are tied into different institutions and how people in them are framing mental illness as a kind of problem. So when mental illness is framed as a problem of urban policy and public space, tied perhaps to the homelessness crisis, and this is something we see in public safety net clinics, the social prognosis they're imagining and the kind of recovery they're imagining for their clientele is making somebody to be not homeless, not in jail, and not triggering too many 911 calls. That's kind of what they're aiming for. And this leads to a certain set of interventions that come to make sense and become taken for granted in this space. And those are things like the housing first approach to homelessness and a general kind of harm reduction model. That's the key intervention there. And then on the other hand, when mental illness gets framed as a problem of privileged family crisis, and this is what's going to be happening in these elite private clinics, the social prognosis, the imagined future they have for these clients is very different. It's about generating class respectable identities. So that could mean something like returning to college after a psychotic break, developing hobbies, working some sort of job, or healing some sort of rifts in the family. And this is going to require a very different set of treatments than the kind of housing first harm reduction we see in the public sector. These are various types of therapies intended for kind of normalization and behavioral transformation. Okay, so I know that sounds pretty abstract at this point, but I'm going to work up to this analysis of social prognosis throughout the talk. And once you've seen the different dimensions and the qualitative data I'm going to present comparing these sectors, I think it should be a lot clearer. And so now I'm going to talk about three social science areas, research areas that I'm building on and bringing together and trying to do something a little different with. So first is going to be research on class inequality and the thing we call serious mental illness. Second is that on labeling and self-fulfilling prophecy. And third is going to be the emergence of the recovery perspective, both in academia, but also in social movements and then in the clinical world. So first, this stuff on class inequality and serious mental illness. So a classic longstanding finding of psychiatric epidemiology is that poverty and hardship are associated with serious mental illness. So you may be familiar with gradients like this that show that as incomes rise, you tend to see lower rates of serious mental illness. And people debate exactly, what this means or what explains it. So this is often framed in terms of what they would call social causation versus social drift. The social causation idea is that people who are marginalized are simply exposed to more stressors, which can either induce or exacerbate mental illness. The other argument, the social drift argument, is that when people are seriously disabled, they're more likely to kind of fall through the class structure and become poor. And then a lot of research has looked at how these things actually compound one another. So another idea I'm engaged with here is how labeling people can generate self-fulfilling prophecies. So the classic sociological literature on labeling theory was interested in how labeling somebody as a deviant might create that said deviance. So a classic example would be labeling a child a delinquent, whatever their behavior was. And so if it ends up changing their self-concept and how the school or the family ends up viewing them, it may actually lead them, or so the theory goes, to engaging in delinquent acts and sort of confirming the initial diagnosis there. And a bold claim was made by labeling theorists in the 1960s and 70s around mental illness, that diagnosing someone with, say, schizophrenia could lead to changes in self-concept and how society views them, and then induce seemingly, quote-unquote, crazy behavior. Now, by the 1980s, they'd shifted to what they were calling modified labeling theory. No one was, generally speaking, making still these claims that mental illness was fully socially induced. But there was a lot of research showing how labeling someone with a diagnosis could generate stigma and rejection. And so there's a lot of documentation of these kinds of negative self-fulfilling prophecies. And then precisely because of these negative self-fulfilling prophecies, ex-patient and psychiatric survivor activists became very concerned with getting clinicians and society more broadly to have a more positive outlook for the possibilities of recovery. And this starts out as a kind of radical idea, but then ends up becoming quite mainstream, institutionalized in things like the Bush New Freedom Commission on Mental Health. And here's just one definition. Recovery identifies and builds upon each individual's assets, strengths, and areas of health and competence to support the person in managing his or her condition while regaining a meaningful, constructive sense of membership in the broader community. Okay, so in light of these different literatures, I'm going to try to shift the questions a bit. So I'm not asking with the social causation and social drift literature, are people poor because they're sick or sick because they're poor? I'm not really focused here on how these negative beliefs are generating self-fulfilling prophecies. And I'm not really asking our clinics doing a recovery model. What's interesting nowadays is that many clinics are steeped in the kind of recovery language. They claim to be upholding a kind of positive vision and a holistic approach to patients. But they have very different definitions in practice of what recovery is. And that's what I'm going to focus on. So I'm going to ask questions like, what defines recovery for people of different social classes? And then how do these visions shape care practices and client lives? So just a bit about the research methods. So this was based on a long-term participant observation where I shadowed workers, service users, families, homeless outreach. So from 2013 to 2015, I was with the LA County Department of Mental Health with one of their intensive treatment programs. I did a lot of street outreach as a volunteer, home visits, attended groups, things like this. And then I switched gears and went across the proverbial tracks to elite private agencies. I was an intern at what I'm going to call the Actualization Clinic, which is a case management for rich people. I should point out, these are the kind of places that only sometimes take insurance. In many cases, it's cash pay. So we're talking in many, between these kinds of intensive outpatient programs or residential treatment, people need a fair amount of money. Or they'll burn through their money pretty quickly. So this clinic, in turn, introduced me to a variety of linked providers in this sort of network of elite care. So I went to residential treatment facilities, different forms of groups and meetings. I will say one difference was that I had limited access to home visits because part of what rich people are paying for is to remain somewhat anonymous. So I'm going to talk about 4 points of comparison to think about these different clinics. So the first is what I'm going to call the clinical project, kind of like what is it that they think they're up to? The second, I'm going to focus on this social prognosis. How are they imagining recovery? What is their vision for people? The third part is going to be about mismatch. So what happens when an individual doesn't quite fit into the social prognosis that's kind of common within that clinic? And then fourth, I'm going to turn to this question of client choice. So how do they understand client choice? And again, the hope is that what seems obvious when it's in its own context, when we put these things side by side, will be a bit more interesting. So first, this clinical project, kind of how do workers understand their purpose? And what I find is that the Department of Mental Health, this is LA County, but I think common for a lot of public safety net providers, they're managing mental illness, but in the context of managing urban poverty and sort of low-level social disorder, right? They're in some sense tasked with also addressing homelessness, things happening on the street. On the other hand, at the Actualization Clinic and the elite private sector, they're addressing mental health in the context of family crisis, in many cases because families are the ones who are coming to the clinic and paying out of pocket. And then they're also addressing kind of lost identity. This is how they see what they're doing. It's recovering identity for people. So at the Department of Mental Health, again, like housing the homeless is primary part of what they do. And here's what Laura, the team leader of this case management team, said to me once. She said, "We're not so good at the rehabilitative side. It's no one's fault, really. It's just once we've covered the basics with one person, we have to move on to the next person to get them housed." So this kind of dominates a lot of time, how they view what they're doing. But I also found this is also what's being quantitatively prioritized in their metrics. So when I was starting field work in 2013, I was reading through a county outcome data report. And the first line they had describing these programs, it's known as a full service partnership. It's the kind of most intensive outpatient model from the California Mental Health Services Act. Here's what they said. Adult programs have demonstrated a 67% decrease in homelessness, 35% decrease in jail days, and 15% decrease in hospital days, which are all very reasonable things to focus on and are important. But it sort of shows you this is how they're thinking about what they're doing, is trying to say reduce homelessness and reduce jail days. And then others have even a more cynical read on this, which is that it's primarily about saving money. So here's what Mr. Daniels, who runs a board and care home, a psychiatric group home in LA, once told me. He said, "You know the economics of this thing. One of the reasons why we exist, and I don't just mean us, is so that people are not burdening Medi-Cal and therefore the state and their budget by being in the hospital." So how do they think about the clinical project at the Actualization Clinic and these other elite privates? It's something very different. They frame it in terms of protecting family reputations and feelings. So here's what Richard, the owner of the Actualization Clinic, said to me. He said, "A manic or psychotic person with resources and connections can do so much damage, you wouldn't believe it, to their family business, to their community. So there's this kind of social management function. But it also comes along with a very hopeful vision of sort of recovery that involves rebuilding patient identities. So here's what Deirdre, the actualization clinical director, once said. We're not interested in how many hospitalizations have you had and what are your umpteen diagnoses. Do you want to make friends? Do you want to recreate? Do you want to go to school? Let's do it. So this very different vision. And there's expectations that people might really lead quite robust lives. Here's what William, who owned another private treatment team, who sometimes collaborated with the actualization clinic, he said, I feel completely unlimited in what our clients can achieve. So, a family, kid's job, their symptoms are integrated into their lives where they don't bother them, or maybe they even begin to see them as gifts. We dream kind of big about what we can do because you're not worried about the socioeconomic stuff. Okay, now I'm going to turn to this idea of social prognosis and sort of see it in action. So how do the two clinics interpret and process people with arguably similar psychiatric profiles, but very different social profiles? So I'm going to tell you about Delilah and Gwen, who are both women in their 50s who are diagnosed with major depression with psychotic features. So at the Department of Mental Health, Delilah is a poor African-American woman who was living on the street. And at the actualization clinic, Gwen is a wealthy white woman who was brought in by her family. So at the Department of Mental Health, again, as I mentioned, a lot of what they're focused on doing is just trying to achieve this kind of baseline housing stability. And so they were able to help Delilah get off the street. She eventually ended up in her own apartment. And I went with the case managers basically to check up on her and to check to see if she was in crisis. So there was, for instance, there was a time when they suspected she wasn't eating. So they would go do a home visit just to see, does she need to be placed in the hospital, for instance. So that's kind of this maintenance level. And yet this was deemed a success. And in some ways, the trajectory from the streets to apartment was a success. And if you talk to Delilah, she'd say, it's in some ways a lot better, right? She says, here's how she describes her life. I sit at home and I watch TV or listen to some music. I listen to a lot of gospel. I stay in my room singing and reading the Bible. And the big success here, too, is that she's staying indoors. And then the kind of next hopeful vision for her future, a case manager said to me, Delilah, she's ready for that next step. And their imagined future, this prognosis they had for her was that she could eventually age into senior housing, and then she would no longer have to live in a building that was all tied to mental illness and other mental patients. So that was kind of like their vision of what her future could be. At the actualization clinic, there's something very different, their vision of the future here. And so they became focused on what they were calling recovering Gwen's voice, in the sense that they said, she seemed to have lost her voice in her family system. So Gwen had come in. She had come out of a long-term psychoanalytic residential program. There was a myriad interventions, so different medications, like convulsive therapy. And then I met her when she was in the intensive outpatient program at the actualization clinic. And here's how a psychologist at the actualization clinic was talking about Gwen. And this psychoanalytic model. I had a similar patient who had become psychotic after being a supermom and member of the community, not consciously, but the psychotic issue was an exit strategy. And we could debate whether or not this is, a correct kind of psychodynamic interpretation, but there's, a significant difference, which is they're trying to make sense and give possible meaning to her psychotic symptoms. Where was it coming from? What did it mean to her, sort of subjectively or unconsciously? And talking to Gwen, she had an idea of her future that made sense here. So she told me, I want to put myself back together. It's a big life change to have your kids grow up and leave the nest. And Gwen was talking about how she had come to see, and this was a narrative that they'd come up with at the psychoanalytic residential program, that her recent experiences were tied to the fact that she had given up her career identity to be a stay-at-home mom, but now that her kids had left the nest, she suddenly had no identity and it was in crisis. And this leads to certain ideas about what it is that they're doing for her. So again, to sort of reclaim her voice in the family system, they focused on this thing about trying to tell her family no, to be more assertive, to not just be a kind of mother maid. And they wanted her to return to work. So this very different kind of future that's imagined for somebody like Gwen in a clinic like the actualization clinic. Okay, so how do these visions of recovery, though, sometimes become detached from clients' apparent needs? So these things can become mismatched. At the Department of Mental Health, I would observe in some cases clients who seem to be recovering, you could say psychiatrically, but not socially, and sometimes have experienced these kind of benefit traps, which we'll talk about in a second. At the actualization clinic, it's another problem, which is sometimes they had very normative expectations of what people were supposed to do, again, tied to these kind of upper middle class, upper class values. And so you had people who sort of weren't making it by those standards. So here again, it gets to this question of like, what is success in a place like the Department of Mental Health? So Jeremiah was a Jamaican man in his 30s, diagnosed with schizophrenia. I'd first met him during street outreach. He was standing on the street. He had a towel wrapped around his head. He was muttering to himself. The DMH workers decided he was part of the target population. They eventually got him into housing. He responded well to Risperdal. He had significant weight gain, but to his mind, that side effect was worth it. And then he's sort of stable and living indoors. And a case manager said about Jeremiah, that's what hope looks like. But for Jeremiah, he didn't quite experience it this way. So here's what he said. He said, he was appreciative of what the clinic had done for him, certainly. He said, housing, food, clothes, it should be more too, right? And he's a case of what we might call like symptom recovery without social recovery. So here's what he said. He said further, when you've gotten the person on the meds and they're doing fine, you want to get them to the point where they're working instead of just not having anything to do or feeling that you can't do anything, I'm still young. He felt he still had something to contribute to the world, but he felt kind of stuck in the situation. He wanted perhaps more vocational training and to find a new job. But he, as with so many people, also encountered concrete disincentives to this. These kind of benefit traps where graduating from the program could lead to the loss of some of the housing subsidies he was getting from the Department of Mental Health. As with so many others, there's always this question of and fear of working too much income could lead to the risk of one's insurance or other benefits or housing benefits. So the mismatched social prognosis is very different in a place like the actualization clinic because you have this dominance of a classed family viewpoint, and again, particularly upper middle class and upper class. And so as an example of this, Herbert was a man in his 30s diagnosed with schizophrenia, and the actualization clinic had sort of helped him achieve what they saw as a significant psychiatric rehabilitation goal. Was that he got a job at a P.F. Chang's chain restaurant. But then his family encouraged him to quit, which he did, because in their words, he can do much better. And so this was tied to a kind of upper class vision of what recovery should look like or of what a person is supposed to do. The other interesting thing is unlike the kind of trap that someone like Jeremiah was in, is that there's a trap sometimes of optimism. So a very interesting thing happened. I got to know a man named Anthony who just turned 50, diagnosed with schizophrenia. He actually was from out of the area. He was kind of actually a medical tourist who'd come from another country to go to treatment in LA. So his family was spending quite a bit of money. And he was telling me about how, my biggest dream is to be cured and married. And he envisioned this life of different kinds of successes. And what was very interesting is that when I talked to the clinicians, they actually had very little faith in his dream. So here's what the director of the IOP said. His brother is married, has a couple of kids, and runs a successful business, and Anthony wants all that. But he's 50 and he's still struggling with his hallucinations. Treatment providers may have a different view of the likelihood of his ultimate plan succeeding. You don't want to discourage them from their dreams in any way. Nobody knows the future. So there was this very interesting thing where Anthony was putting in all this sort of work in the groups and attending different things and hoping for this dream. And the clinicians wouldn't say, but in fact, they didn't think that it was possible. We can have a kind of cynical read on this that says, oh, it's just about, they're trying to keep him in treatment to extract, money from his family who's paying. But my sense more was that this is what happens in a place like this. This is what gets taken for granted here, that this is kind of what you're driving towards. Okay, and now I'm going to turn to this issue of client choice and how it varies in these different sectors. So how do these social prognoses and visions of the future shape practices around client choice? And so at the Department of Mental Health, because the vision of recovery is making somebody housed and not in jail, it leads to a kind of generalized harm reduction approach without much sort of vision of kind of clinical transformation. And at the actualization clinic, on the other hand, because recovery is wrapped up in upper middle class and upper class notions of respectability, it can actually lead to kind of paternalistic micromanaging that I would say sometimes surprised me. So at DMH, how do they think about client choice? Well, in a way, they've come to see so-called problem behaviors as de facto choices and client choices to be respected. So Laura, here's the team leader. She was responding to a nurse who was saying, "Why are we putting these people who seem to be quite ill in their independent apartments?" And Laura said, "At least they're safe. People like them are not going to do what we want. But what can we do? These are the behaviors that kept them in the streets." So a kind of resignation to this is just how it is. And what can end up happening here is things like housing first, right? Like getting people into independent housing without preconditions of sobriety or psychiatric compliance. It can become what I call tolerant containment. So this is a kind of stripped out version of a harm reduction model, or perhaps housing first, but really housing only, not with the robust services that are supposed to be attached. And this idea of tolerant containment is about the spatially specific acceptance of perhaps formally criminalized problem behaviors. And it ends up being about keeping people alive and keeping them out of the way. So as an example, I would see things like attempts to redirect these quote unquote problem behaviors, primarily to avoid eviction. Because again, keeping people out of the homelessness cycle is the key goal of what's going on here. So as an example, Sandy was a white woman in her 40s, diagnosed with schizophrenia, who was outreached in Skid Row. She moved into an apartment, and the problem they saw was that she would bang her head on the wall she shared with her neighbor. Now, her neighbor is paying market rate in Los Angeles, a lot of money, is very upset, and is trying to basically get her evicted. And so the solution that the social worker came up with was she told Sandy to not bang your head on the wall you share with your neighbor, but bang your head on the wall that goes out to the street. A very creative kind of solution, in part because they didn't really see an option for kind of more significant behavioral transformation. But whatever it did took to keep her from being evicted. And the next part of this was because then she was still at risk of eviction, doing what I call finding the right ecological fit. So actually moving somebody around different parts of the city. So here's what Beth, the social worker, said to Sandy. "You can choose to live like this, but not in this building. We might need to find you a dirtier building." And what that ended up meaning practically here was they did eventually end up moving her from that apartment building with more middle-class market rate people to back into downtown, to a place that was quite chaotic. Now, we can also get an interesting read on what's happening in the public safety net by contrasting it with what's going on at elite settings and how they think about this. So Dev is a guy who has quite interesting insights, because he himself had a psychotic break in college and then attended the actualization clinic and elite private treatment, and then ended up becoming a social worker. And through his social work internship, ended up working at a housing first program. And he, on the one hand, said he really appreciated what they did and thought they were doing important work, but it also made very little sense to him from a private care perspective. And here's how he explained it. The housing first programs don't care if you don't take meds, even if you do drugs to a certain extent. They're more kind of about keeping you out of prison, keeping you out of the revolving door of hospitalizations. It's ultimately their goal. It saves the county a lot of money. What if you want more than that for your loved one? And from his perspective, if you wanted more than that for your loved one, it would actually mean not sort of accepting their choices at face value. And so at the actualization clinic, I would see these different attempts to kind of manage people's choices. One technique would be like removing the choices available to people to try to get them to choose something that was within the sort of normative bounds. So as an example, Roy was a man in his 30s who was diagnosed with schizophrenia, experiencing what would be called negative symptoms. He basically wouldn't leave the house, and he read comics and watched TV. And the actualization clinic gave him sort of narrow options to choose from. They said, you can't do those things. And so he ended up choosing one. I sort of affectionately call here restaurant therapy. The thing they would do is they would take him to busy restaurants to help him sort of learn to tolerate being in these social environments again. And here's how they talked about it. Here's what Deirdre said to a case manager who was working with him. We don't want to infantilize our clients, but it's like with my kids. If I ask them what they want to do, they want to be on their phone. You want a bike ride or get something to eat? If they want something else, you say, sorry, that's not an option. And at times this could lead to a strange kind of domination that was very different than anything I saw in the kind of public safety net world. With a kind of obligation in some sense to normalization and to a sort of increased quality of life. And I'll give you an example here. Kayvan was a Persian man in his 60s diagnosed with schizophrenia. He was being seen by Dev, the social worker I mentioned before. And Kayvan believed that any new activities would lead to a catastrophic event in his brain. Well, Dev basically made him play soccer. I was with them when they played soccer. And then Dev said, we're going to make you do more new activities. And Kayvan said, Dev, please, no. And Dev finally puts his foot down and he says, it would be a disservice if I allow this to continue because it impacts the quality of your life. And later that day, here's what Dev said to me. He said, you know what, the private sector, I don't know if the word is you can get away with more, but for instance, with Kayvan, we push through things. But in the public sector, I might not be able to do that. They could think that's not ethical. But of course, for Dev, he was the one who was being ethical by pushing through things. Okay, so in summary, to return to this idea of the sort of social prognosis. So the social prognosis refers to the types of lives and identities people with mental illness can expect to have. And my argument is that the social prognosis is tied to different types of clinical institutions, the ones for the poor versus the rich here. And these different environments have different goals. So this vision of recovery, it's shaped by the context more than perhaps the actual client. And so that could end up meaning the processing and treatment of the person can sort of become disconnected perhaps from their particular capacities or needs. And so, as mentioned before, we put these things side by side and we can sort of see them more starkly and know what makes sense in each world. In contrast, we can maybe think about more critically. So what's the clinical project? So Department of Mental Health, it's this idea that you're managing urban poverty as much as you're addressing mental illness. At the Actualization Clinic and their sister programs, it's focused on these kind of family systems work. The social prognosis at the Department of Mental Health is they're imagining that they can get a person to be housed and not in jail, and that's what they work towards. At the Actualization Clinic, it's about building respectable identities. This can create a mismatch at the DMH by sort of ignoring client dreams beyond just being a housed person. With actualization, there can be these problems because of the assumption of normative achievement. And then it can lead to these very different ideas around client choice. So the Department of Mental Health, a kind of harm reduction and radical acceptance of seemingly problematic choices. The Actualization Clinic, a real intense focus on creating the seemingly proper choices for that class milieu. Okay, so what are some of the consequences for clients here? I mean, so the risks in the public safety net is that recovery is highly constrained. Client dreams beyond simply, being put somewhere out of the way end up getting ignored. There's few kind of aspirations for broader improvement in people's lives. And then, as I mentioned, even I think important interventions like housing first can descend into mere tolerant containment. Now, the risks in elite care are very different. Oftentimes, the family viewpoint, especially because the families are the paying ones, it can become too dominant. This can lead to kind of inappropriate goals. At times, I saw highly individualized treatments actually become too individualistic. There actually wasn't much of a focus on social integration. And then I didn't get into this much in this presentation, but something I addressed in the book is actually the lack of a harm reduction model in some of these higher end places means that clients who they probably could have engaged, they just sort of end up sending on their way. And so, what can we do about this? So, I mean, one thing at the organizational level is that we really need to rethink what the metrics of success are, right? So in some of these public safety net settings, you need to be able to think beyond just measuring housing outcomes, keeping people out of jail, saving money. On the other hand, in some of these elite settings, it's going to be important at times to push back against family demands and expectations. This could also lead to changes in the frame for how we think about training people. say clinicians, right? So sometimes the question is asking like, are the visions here of the client's future based on the client and their needs, or is it based on kind of the milieu? Like what happens to people like this person in this kind of setting? So I think the idea of social prognosis could perhaps be part of kind of instruction, what people are calling structural competency. And then, what also needs to happen, of course, is significant policy changes. So the social prognosis can't change without material and cultural changes, right? So we can hardly expect a place like the Department of Mental Health in LA County, especially downtown, to not be focused primarily on things like keeping people housed and out of jail. Those are very reasonable goals because we have a homelessness and criminalization crisis. But it does end up constraining kind of the vision of what people can and should achieve. And then to do this, right, it can also require work with advocates, social movements, and political actors, as opposed to focus on the individual. Okay, thank you. I look forward to discussions in these following sessions.